Welcome to Effective Treatments for the Neck and Head, a manual therapy course to improve your treatment of radicular pain and foraminal impingement syndromes. Traditional treatment of cervical radiculopathy is usually hit or miss because little is known about the natural history of this condition. If there's no significant improvement with non-operative treatments, epidural corticosteroid injections or surgical intervention may be considered. The long-term outcomes do not differ between those who undergo surgery and those who do not. By understanding the true nature of this disorder, you can begin a treatment program that will target causative structures instead of just treating symptoms with operative and non-operative patients. This seminar will first focus on the tonus and phasic muscles of the upper torso and how they influence major joints of the neck. Once these muscles and surrounding fascia are released with an easy-to-follow protocol, all that's left is to provide follow-up exercises the patient can do at home. Here's a lineup of topics to be covered today. Why massage therapy? Doing it to or doing it with? Forces beyond the neck's control? Dissecting the neck? Lesser is more. Review of the basics. Assessment is the key. Treatment for the neck. TMJ and treatment. Active isolated assisted stretching. Kinesiology tape treatment. And finally, self-treatment. Why massage therapy? For the person in pain, the answer may be because it feels good or because my doctor prescribed it. For the therapist, the pragmatic answer might be because it gets results. But interestingly enough, when this person presents with serious degenerative disorders like cervical radiculopathy, disc herniation, or osteoarthritic changes of the neck, very few doctors would think to call on massage therapists. In my personal experience of having the disorder cervical radiculopathy, my success was not from traditional medical treatments. My condition improved with massage therapy and other tissue manipulative approaches, but finally the answer came from re-educating my own body and by asking, how did I get here? Doing it to or doing it with. I feel the greatest dysfunction that patients that I treat all suffer from is lack of awareness of their body. There are two approaches applied by therapists working on the person and working with the person. Every massage stroke is one or the other, doing it to the person or doing it with them. It is either forcing them to relax or helping them to discover that they're contracting their muscles and fascia and teaching them to relax when until then they had forgotten how. Done passively, tissue manipulation evokes or calls forward a gradual deepening of the person's awareness and control of their muscular actions. But this deepening is greatly limited by the lack of sensory feedback that active movement provides. Tissue manipulation done with active participation by the person evokes more than relaxation and flexibility. Because the person has enhanced awareness of the connection between sensation and movement, their control of movement improves much faster. Forces beyond the neck's control. Before effective treatment of the neck can begin, we need to first look at the tremendous forces at work. With a relaxed individual with minimal stress and excellent posture, the neck balances the head equally on all sides. No one side is pulling more than others. With my condition of cervical radiculopathy, the scalene muscles had shortened so much that it was compressing my intervertebral discs, which led to tingling and radiculopathy going down to my fingertips. I had also lost a good majority of my cervical curve, which should be 63 degrees. At this point, all of the surrounding musculature was compensating for all of these changes that had taken place. If this relaxed person bends over, things change in a fraction of a second. The muscles of the back of the neck have to stiffen to keep the head up and the eyes forward. This protective mechanism is called the law of righting, or simply the righting reflex. It states the eyes will always be level with the horizon, regardless of what happens with the rest of the body. So the most important, as far as the body is concerned, is keeping the eyes level, regardless of what the rest of the body has to do in order to keep this. Many factors come into play in a person's life: improper posture, injuries, emotional trauma, environmental, with the effect, if done often enough, will affect the tissues of the neck to forget the balanced state it once had. Most conditions of the neck, from pain and tightness to medical diagnosis of cervical radiculopathy, disc protrusion, or herniation, and even osteophyte reactive changes, can be traced back to previous trauma or imbalance. But today, it's rarely thought of when treating the neck. A number of muscles of the neck remain major players in keeping an imbalance that over time multiplies compression to lead to disc degeneration. Professor Vladimir Janda, rehabilitation consultant for the World Health Organization, was one of the first clinicians to bring this theory to light. Professor Janda is best known for his identification of 3 postural syndromes: the upper or proximal crossed, lower distal or pelvic crossed, and layer syndromes. Briefly, each of these clinical scenarios describe conditions in which the tone of antagonistic muscle groups became imbalanced and led to the predictable sequence of pain and dysfunction. Once the specific patterns of imbalance and impairment have been determined, a specific exercise program is implemented. The general progression of treatment involves the normalization of peripheral proprioceptive structures, normalization of tight muscles, facilitation of weak or inhibited muscles, and finally coordination of movement patterns through specific exercise. By researching Dr. Yanda's work, patterns started to emerge of tight muscles on one side and weak muscles on the other side. Essentially, tighter tonic muscles shorten, while phasic often weaken. As I discovered, it's not enough to just relax tight muscles. One must strengthen weak muscles and re-educate all associated muscles to achieve balance. In addition, Sherrington's law of reciprocal inhibition states that a hypertonic antagonistic muscle may be reflexively inhibiting their antagonist. Therefore, in the presence of tight and/or shortened antagonistic muscles, restoring normal muscle tone and/or length must be first addressed before attempting to strengthen a weakened or inhibited muscle. Dissecting the neck. Before the musculature of the neck can be examined, we must look at the movements we should be capable of. A rarely discussed subdivision of flexion and extension is capital and cervical. With capital movement, it's just C1 and the occiput. This is the motion of nodding. So the cervical vertebrae are not moving. What's moving is the cap. With cervical movement, it comes from C2 to C7. This is the actual movement of the cervical vertebra. If you combine both capital and cervical together, the person is looking straight down or they're looking straight up. So this movement is actually a combination of 2 different groups. Specific muscles in the neck will influence usually one of these types of motions. Let us first explore what's termed as postural muscles of the neck. If you were to dissect 60% of the muscles of the neck short of the postural ones, the head would still remain in a balanced position. These postural muscles have specific actions as well as supporting the head in an upright position. Over time, these postural muscles are subdued by lesser muscles that have become stronger from improper habits. The postural muscles that used to support the vertebra are now ineffective and gradually become weak. Longus capitis. The primary function of longus capitis is capital flexion, so it's the forward motion of nodding. Interestingly enough, it's not uncommon to find people that have a challenged motion, either capital or cervical. A way of strengthening this muscle would be to apply pressure to the forehead and have the person nod forward. Longus colli. Primary function is cervical flexion. So these are the cervical vertebra, not the cap. So this motion is closer to this torso than capital flexion. Sternocleidomastoid, the primary function is cervical flexion. Multifidus, the primary function is cervical and trunk extension. Rotatories, the primary function extends and rotates the vertebral column. Semispinalis capitis, the primary function is capital extension. Now, as we explore the stronger lesser muscles, keep in mind this illustration of extreme collapsed posture with a forward head and hunched shoulders. Of course, nobody walks around like this, or do they? Now let's look at the lesser muscles, or phasic. The lesser muscles, while still performing their primary function, have taken on the job of supporting the vertebra and the head. It's much easier to see why the lesser muscles have become stronger. They never stop working. It's also interesting to note that there are twice as many extensor muscles as there are flexor muscles. Lesser is more. Suboccipitals. The primary function of suboccipitals is capital extension. No wonder these are always very hypertonic and sensitive. Longissimus capitis. Primary function is capital extension. Splenius capitis. The primary function is capital extension. Semispinalis cervicus. The primary function is cervical extension. Splenius cervicus. The primary function is cervical extension. Iliocostalis cervicus. The primary function is cervical extension. Longissimus cervicus. The primary function is cervical extension. The scalenes, anterior, middle, and posterior. The primary function is rib elevation during inspiration. To help you to appreciate how overworked the lesser muscles are, for every inch that the head moves forward in posture, it increases the weight of the head on the neck by 10 pounds. A forward neck posture of 3 inches increases the weight of the head on the neck by 30 pounds, and the pressure put on the muscles increases just to hold the head up. Review of the basics. As we continue to unravel this complex region, let us see what's been discussed so far. Most conditions of the neck can be traced back to previous trauma or imbalance. Improper posture over time will cause the postural muscles to become ineffective and gradually become weak. Lesser muscles, while still performing their primary function, have taken on the job of supporting the vertebra and the head. There are twice as many extensor muscles compared to flexion muscles. Assessment is the key. In order to effectively treat the classic forward head posture, in which most degenerative conditions arise, assessment skills must be practiced and perfected. These assessment tools will show us three things: are regions of the body compensating for structural instability? Which specific muscle or tendon is affected? Is it a muscle, tendon injury, or ligament, joint injury? Systematic evaluation of muscle imbalance begins with static postural assessment, observing muscles for characteristic signs of hypertonicity or hypotonicity. Try the wall test for neck posture. Stand with the back of your head touching the wall and your heels 6 inches from the baseboard. With your gluteal touching the wall, check the distance with your hand between your neck and the wall. If you can get within 2 inches at the neck, you're close to having good posture. This is followed by a series of question and answers. When did you first notice the problem? Can a certain movement reproduce any type of pain? If you used any previous treatment, was it helpful? Any muscle aches, tension, headache, or jaw problems? Next, characteristic movement patterns are assessed, and specific muscles are tested for tightness or shortness. This is usually referred to manual muscle testing or muscle assessment. There's such a wide variation of the grading scale with normal adults. For our purpose, a much gentler version will be used. In most cases, pain will point to muscle or tendon damage during these assessments. With manual muscle assessment or functional assessment protocol, resistance or pressure from the therapist is only 1 to 2 pounds. Direction of resistance follows the black arrows on the illustration, and the assessment is performed for a maximum of 5 seconds. Capital extension. The subject is prone with the head off the end of the table and the arms are at the side. The therapist is standing at the side of the table next to the head. One hand provides resistance over the occiput, 1 to 2 pounds only. The other hand is used if support is needed. The subject extends their head by tilting their chin upwards in a nodding motion. The cervical spine is not extended. Instructions you can read to them: look at the wall, hold it, and don't let me tilt your head down. Hold that for 5 seconds. Cervical extension. Prone with the head off the end of the table, the arms are at the side. The therapist is standing next to the subject's head. One hand is placed over the subject's back of the head for resistance. The other hand is placed below the chin if support is needed. The subject extends the neck without tilting the chin. Resistance is only 1 to 2 pounds. Instructions: push up on my hand but keep looking at the floor. Hold it and don't let me push it down. Capital flexion. Supine with the head on the table, the arms are at the side. The therapist is standing at the head of the table facing the subject. Both hands are cupped under the mandible to give resistance in an upward and backward direction. Only 1 to 2 pounds maximum. The subject tucks their chin into their neck without raising the head from the table. No motion should occur at the cervical spine. This is a downward motion of nodding. Instructions: tuck your chin, don't lift your head from the table, hold it, and don't let me lift up your chin. Cervical flexion. Supine with the arms at the side, the head on the table. The therapist is standing next to the subject's head. The hand for resistance is placed on the subject's forehead, only 1 to 2 pounds. The other hand may be placed below the chest, but stabilization is needed only when the trunk is weak. The subject flexes the neck by lifting the head straight up from the table without tucking the chin. Instructions: lift your head from the table, keep looking at the ceiling. Do not lift your shoulders off the table. Hold it, and don't let me push your head down. Lateral flexion. Supine with the arms at the side, the head on the table. The therapist is standing next to the subject's head. The hand for resistance is placed on the subject's side of head to be tested. The other hand is cupped around the shoulder for support. Only 1 to 2 pounds of pressure. The subject laterally flexes the neck without lifting the head from the table. Instructions. Keep your head on the table, bring your ear to your shoulder, keep looking at the ceiling. Do not lift your shoulders off the table. Hold it. Don't let me push your head to the side. Quiet inspiration. Position of the subject is supine. The therapist is standing next to the subject at waist level. One hand is placed lightly on the abdomen just below the xiphoid process. Resistance of 1 to 2 pounds only is given by the same hand in a downward direction. The subject inhales with maximum effort and holds maximum inspiration. Instructions. Take a deep breath as much as you can. Hold it. Push against my hand. Don't let me push you down. Diaphragm breathing inhibits the involvement of overactive accessory breathing muscles and keeps their activity to a minimum during rest. Accessory breathing muscles are designed to assist breathing only during exertion to further expand the ribs, but to remain primarily silent at rest. The most important fault during breathing is lifting the thorax with the scalenes instead of widening it in the horizontal plane. Passive assisted neck stretches. These assessments are used to determine range of motion, and in most cases, pain will point to ligament damage. The person stays relaxed and the therapist is doing the movement. Capital extension. Position of the subject seated, the arms at the side. The therapist is standing behind the subject next to the head. Both hands are placed around the head. The therapist extends the head by tilting the chin upwards in a nodding motion. The cervical spine is not extended. Instructions. Look at the wall, keep your shoulders down and relaxed. Allow me to tilt your head up. Cervical extension. The subject is seated, arms at the side. The therapist is standing next to the subject's head. One hand is placed over the subject's upper back for support. The other hand is placed on the forehead. The therapist extends the neck without tilting the chin. Instructions. Look at the wall, keep your shoulders down and relaxed. Allow me to tilt your head back. Capital flexion. The subject is seated or supine with the head on the table. Arms are at the side. The therapist is standing at the head of the table, facing the subject. Both hands are placed around the head. The therapist tucks the chin into the neck. No motion should occur at the cervical spine. This is a downward motion of nodding. Instructions. Keep your shoulders down and relaxed. Allow me to tilt your head forward and tuck your chin. Cervical flexion. The subject is seated or supine with the head on the table. The therapist is standing behind the subject's head. One hand is placed on the back of the subject's head. The other hand is cupped around the shoulder for support. The therapist flexes the neck by pushing the head forward without tucking the chin. Instructions. Keep your shoulders down and relaxed. Allow me to tilt your head forward. Lateral flexion. The subject is seated or supine with the head on the table. Arms are at the side. The therapist is standing next to the subject's head. One hand is placed on the subject's side of the head to be tested. The other hand is cupped around the shoulder for support. The therapist laterally flexes the neck by bringing the ear to the shoulder while pushing the shoulder in opposite directions. Instructions. Keep your shoulders down and relaxed. Allow me to tilt your head to the side. Continue your assessment by noting any weaknesses of muscle strength, lack of motion, or pain during movement. Massage treatment. A combination of techniques and modalities are required to effectively treat the neck area. The goal is to lengthen short, hypertonic muscles with deep tissue, myofascial release, friction massage, and active isolated assisted stretching, which have been found to elongate this dysfunctional tissue. If your assessment skills are sound, you should have a good indication as to where you need to focus your work. Keeping in mind Yanda's upper cross syndrome, a predictable sequence of tightness and weakness. Through experience, most problems of the neck dealing with muscle tissue seem to come and go. With chronic complaints over years, ligament damage and structural changes occur. Posterior neck. This area will require much of your work, so I prefer to work one layer at a time with minimal discomfort to the person, starting in the prone position. The person eventually will turn over supine, continuing to attack this highly problematic area many times. Muscle fibers cross in different directions, with each muscle having the ability to stick or adhere to the layer below. Trapezius. In the prone position, warm up the tissue with gentle strokes directed in either up or down movements. Dynamic extension release. Movement is performed by having the person start in cervical extension and slowly lowers the neck into cervical flexion while you stroke the trapezius. Dynamic extension release works with the premise of reciprocal inhibition. If you can contract the opposite muscles, which in this case would be cervical flexor muscles, the nerve signal is going to go to the front and allows the back to let go. So you'll actually be able to work into the deeper layers of tissue with less discomfort from the patient. If any adhesions are found, go against the grain and smooth out any restrictions. In some instances, holding the restriction until it softens is helpful. Note any referral pain patterns. Extension muscles. As the trapezius releases, focus your intention working the deeper layers of the extensor musculature. Follow the same procedure as in the previous muscle, smoothing any adhesions and using dynamic extension release as described earlier. Okay, so there's the trapezius. It goes from up there, comes down to here, attaches onto the acromion, and then goes down like that. So anything you prefer to use, your fingers, thumb, forearm. Dynamic extension is kind of nice to be able to do this. So with this, what you do is you have the person bring their head up out of the face cradle into extension. And as they go back into the face cradle, that's when you work it. And then again, nice and slow. It's a very natural motion and it's stretching at the same time. And to work the other side, bring your head up and then down. It's good. Suboccipitals. If your treatment table is equipped with an adjustable face cradle, lower the angle a few degrees or have the person tilt their forehead down into capital flexion to access the base of the neck. Dynamic extension release in this area is accomplished by having the person move slowly into capital flexion. Intertransverse ligament. The 5th and 7th cervical intertransverse ligament is often injured. In the prone position, it's easily accessible. To find this ligament, go inferior from the mastoid process and push laterally into the side of the neck at the level of C3. You will need to push the anterior fibers of the upper trapezius posterior and remain anterior to these fibers. So you need to be anterior to trapezius and posterior to sternocleidomastoid. Push laterally into the side of the neck and then cross fiber friction anterior to posterior, front to back. You should find a semi-hard structure, which is a transverse process. This area is also the attachment for the scalenes and levator scapula. Continue inferior until you can't go any further. This is the level of C7 vertebra. This is the main culprit with medial scapular referral pain and limited side flexion. After the transverse process is located, gently cross fiber in an anterior to posterior direction to treat the ligament. Note any referral pain patterns. Gently cross fiber any of the higher ligaments, C2 to C6, if pain is present. Suboccipitals, if you don't have an adjustable face cradle, you might want to have the person tuck their neck a little bit as they're coming back down like that. Okay? So you're just working from the mastoid to here, and then have you look up, bring your head out of the face cradle, and then look down, and then tuck your chin. There we go. So as she's doing that motion coming down and tucking her chin, that's when I'm getting in and then working the suboccipitals. Because that tucking is actually what stretches the muscles. The intertransverse ligament is on the lateral side, right there, the transverse process. If you have trapezius, which comes up like this, that goes to there, and then you have sternocleidomastoid that goes down there. So you want to be in front of trapezius at all times. So if you're in front of the edge of the trapezius, then try and push into the middle of the vertebra, or you're pushing in that direction, but you're right on the transverse process. So you'll feel that little structure right there. And just gently cross fiber back and forth. Try and get up as high as you can. Trying to stay in front of the trapezius. It's a very sensitive area, and it contributes to a lot of arm problem and neck dysfunction. Dowager's hump. It's an abnormal outward curvature of the vertebra of C7 found in many forward head postures. Compression of the front or anterior portion of the involved vertebra leads to forward bending of the spine, or kyphosis, and creates a hump at the upper back. If untreated in time, osteoporotic changes will take place. Unless a fracture is present, hypomobile facet joints at the level of C6 and C7 will prevent proper alignment and foundation for the cervical spine, even if balance of the musculature is restored. This condition can also be very hypersensitive, so much care must be taken with this. Work within the person's tolerance. Have the person raise the head out of the face cradle. As the person lowers their head, stroke upwards superiorly on this area. Continue this movement at least 2 more times and stroke in a downward inferior direction. So with dynamic extension, what that is, have the person raise their head up out of the face cradle, and then as they go back down slowly, and as they finish the motion, then arch their back, because that encourages those facets to close. So at least 1 time superior and at least 2 times or more inferior. Supine position. In this position, the weight of the person's head will allow you to generate pressure instead of just doing it yourself in the prone position. Be aware that your wrist has a tendency to flex or extend, which could cause you strain. Posterior musculature. Continue treating all of the muscles of the posterior region. The person's head may be elevated by a pillow, supported with your other hand, or lying on the table. Treat trapezius and extensor muscles. If any adhesions are found, go against the grain and smooth out any restrictions. Note any referral pain patterns. Use dynamic extension release to treat the extensor muscles. Have the person slowly move their neck into cervical flexion as you stroke up or down. Suboccipitals. Treat these muscles with the head rotated to the side. The person's head may be elevated by a pillow, supported with your other hand or lying on the table. Using dynamic extension release, have the person move into capital flexion as you stroke. So the trapezius and the extensor muscles, I usually just work from the ear line back to the midsection there, supporting the head with my other hand. Note any referrals that you might possibly find. Go against the grain and smooth out any restrictions. Dynamic extension. So if you were to have the person using these muscles flex their head like that, so if you would flex your head upwards, and then do it a few more times, nice and slow. So as they're contracting their anterior muscles to do flexion, the posterior muscles are stretching while you're working them at the same time. You can go in any direction that you want, across, diagonal, up and down. So that's dynamic extension. Let me do the other side. So they're actively participating in the therapy. The suboccipital muscles, very tiny little muscles that are used in capital extension. Those go from C1 and C2 and also on the occiput, right in through here. So you could have the person's head elevated by a pillow or supporting with your other hand, lying on the table. And you might have to take it slow as you're getting in there because they're so incredibly sensitive. Dynamic extension move is to have them do capital flexion. So not lifting your head off of the table, but just nod your chin. And as she's nodding her chin in flexion, capital flexion, that's stretching the capital extensor muscles. So as she does that, then I'm going to be working the suboccipitals. Okay, we'll do the other side. So it's stretching those extensors as you're working them at the same time. Intertransverse ligament. After the transverse process is located, under the mastoid process, remembering to stay anterior to the trapezius, gently cross fiber in an anterior to posterior direction to treat the ligaments of C2 to C7. Note any referral pain patterns. So this is behind sternocleidomastoid and in front of trapezius. Dowager's hump. Using medium pressure on C7 area as the person moves into cervical flexion. Stroke in an inferior direction at least 2 times and 1 time going superior. The intertransverse ligament. The intertransverse ligament is difficult to find because the trapezius comes up through here. So it's anterior to the trapezius. So you need to try and remember to stay anterior to that. You want to stay behind sternocleidomastoid, which goes from here to here. So the transverse process of the cervical vertebra kind of sticks out on the side right in through here. So you're just anterior to the trap. It's a little bump that kind of sticks up there to be able to feel it. There's certain spots you won't be able to feel it well at all. But here you should be able to feel it. So you're just behind sternocleidomastoid and you're just in front of the trapezius, pushing into the lateral side of the neck. And you're gently cross-fibering the intertransverse ligament on the transverse process of the cervicals. And you should be able to get from C2 down to hopefully C7. And be aware of any referrals that you might possibly find. Now in some cases you need to go push down in front of the trapezius to get down into that ligament. It's usually pretty sensitive and you don't need a lot of pressure. Next is a dowager's hump. With the dowager's hump, you can treat this in the anterior position as well as posterior. And that's the area that's usually pretty sensitive right about C7. And I find by doing dynamic extension with this, it's a lot easier. So dynamic extension would be to have the person into cervical flexion as that stretches that. So you want to go inferior at least twice and superior at least once. Now, however you prefer to do it, if you want to do the one side and then do the other side, you could do both sides at the same time. I've even taken both of my hands like this and then I'm just stroking, like that. You could use get your thumb in there. So whatever seems to work, and work within the person's tolerance. So if you would, could I have you flex forward, nice and slow, and then come back? And then again. And a couple more times. Now I'm going down. That helps those facet joints to line back up again, and it helps them to move back into place. Anterior neck. This area of the neck is complex, not because of numerous muscles, but because most of the deep flexors are weak, and right next to them are possibly two muscles that are too tight. Weak muscles have a tendency to stay weak because of the reverse effect of the stretch reflex. By incorporating a spindle stimulating technique to, in a sense, wake up the muscle, it's more open to be strengthened. Deep neck flexors. Position the fingers just lateral to the trachea. Gently push in at 45 degrees. Begin a 1 minute of fast-paced circles in all directions from C2 to C6. If there's a chance the person might have a deep venous thrombosis, this movement is contraindicated. The cervical flexor muscles. Being aware that anything in anterior front of sternocleidomastoid is an endangerment site because of the trachea, so you have to be careful there. So I like to stay posterior to sternocleidomastoid. In order to work this area, you need to elevate the head just a little bit. And you're working into the scalenes. If you find a sensitive spot, just hold it and let it soften. So I'm kind of pushing underneath sternocleidomastoid, and I'm getting into longus capitis and longus coli. Sternocleidomastoid. In my experience, I have found this muscle is lengthened most of the time. but only 50% in a weakened state. This might be caused by nature. It's a postural muscle that's subdued by stronger extensor muscles. On the other hand, if these stronger extensor muscles have become injured, the sternocleidomastoid has to spring into action to hold up the head. Grasp this muscle with your thumb and fingers. If your assessment points to weakness, incorporate 1 minute of fast-paced circles on the entire length of the muscle. If your assessment points to tightness, incorporate dynamic extension release by slowly having the person move from cervical flexion to cervical extension while you stroke up and back down the muscle. If there's a chance the person might have a deep venous thrombosis, this movement is contraindicated. Scalenes. With one hand or a pillow, elevate the head at least 30 degrees. Place the fingers posterior to sternocleidomastoid and gently push in at 45 degrees. Move in an anterior and posterior direction, then inferior to superior direction. If there's a chance the person might have a deep venous thrombosis, this movement is contraindicated. You can also perform dynamic extension release by slowly having the person move from cervical flexion to extension, maybe with a little side flexion away from the treatment side, while you stroke up and back down the muscle. Cervical distraction. Gentle distraction must be emphasized. I use no more than 1 to 2 pounds of pressure. Place one hand with a radial carpal aspect at C2, C3 area. The other hand gently stabilizes the head. Move the person into capital extension. Lean away with your body weight only for up to 30 seconds or less. So I'm not using more than 1 to 2 pounds of pressure. Cervical reeducation. Restore joint play and capsular flexibility by grasping the neck and gently move the person into capital flexion, then cervical flexion, then capital extension, and then cervical extension, and then finally lateral flexion on both sides. Next, with sternocleidomastoid, it's a difficult muscle to just push into because you don't want to push into that sensitive area. But if you can somehow grasp this muscle, that will help a lot. So just by kind of pinching it with your fingers, and if you find any sensitive or referral spots, then just hold that spot before you move on. So sternocleidomastoid, I'm just going to grasp it, elevating the head just a touch. One of my favorite ways to work this is to have the person go into dynamic extension. With this, I'm going to elevate your head into flexion and then have you push into my hand and then also rotate your ear to your shoulder. If that's hard for them, just have them push into your hand. Or you can go the other way too if you want. Okay, with cervical distraction, you can use either wrist that if you have a favorite side that you would rather use. With cervical distraction, you would place your hand, you want to flex your elbow with your thumb pointing up to the ceiling. And you want to be right about C2, C3, around that area. So their neck is resting on your arm. Now at this point, all you have to do is just stabilize the head so it doesn't move as you're providing this distraction. So I'm going to be getting close to the table, and I'm going to gently push down on the forehead 1 to 2 pounds. I'm going to lift the head up to get just a touch of extension to help keep this in here. And then I'm going to bring both of my arms back towards me. It's probably about 2 to 3 pounds of pressure maximum. The key to this is to do this so there's no strain on yourself, because it's of most benefit the longer duration that you can do it with less pressure. And when you let go really slowly. Never allow the head to snap back. Cervical re-education is just to help to loosen up these joints. So I'm just pushing upwards into capital extension and then bringing the head down into capital flexion. Then I'm lifting the neck up into extension and back to flexion. You could also go from side to side, very gentle. You could do little circles if you want. Just loosens up those joints. TMJ dysfunction. This condition affects 25% of the United States population and traditionally is treated by an oral surgeon or dental professional with varied results. The reason traditional dental treatments sometimes fail short is failure to look at two other contributing factors that are not as widely known or accepted in medical practice. TMJ dysfunction can be simply defined as a result of unbalanced occlusion or bite. Emotional, inability to relax due to stress. Muscular, tightness of the supporting structures of the head and jaw. Just by addressing the muscular component of this dysfunction will improve or eradicate two of the three causes and could ultimately improve the first, which is unbalanced occlusion. Unbalanced occlusion or bite is a result of teeth which do not fit very well together. It could be caused by teeth that do not line up well or poor posture. One day I was speaking to a dental professional that told me about LVI Global, a dental learning institution in Las Vegas. One of the treatments LVI did for TMJ sufferers was that they used ultrasound on the muscles of mastication to relax the muscles before they took a dental impression to make a bite splint for their TMJ sufferers. And then encouraged me about putting together this soft tissue treatment for TMJ. To effectively treat temporomandibular joint dysfunction, we need to first look at the muscles of mastication, or the closure of the jaw, the masseter muscle, the medial pterygoid, and the temporalis. The largest muscle of mastication is the temporalis on the side of the skull. The thickest and one of the strongest muscles we have in our body is the masseter, which goes from the ramus of the mandible to the zygomatic arch. Here we can actually see the mandible sliding into the TMJ joint during opening and closing of the jaw. On the underside is the medial pterygoids that makes up the third muscle of mastication. temporomandibular joint disorder, the function of mastication should be evaluated to rule out a possible involvement with persons with neck pain or positive signs of forward head posture. Some medical studies are starting to emerge that show a connection of forward head posture and also chronic neck problems, going back to the three primary causes of TMJ. If a person does not present with postural dysfunctions or appear to have extreme muscle tightness, an imbalanced occlusion is likely the cause. The first muscle, the masseter, it's very thick. There are two different segments to them, one running superior inferior and the other is running diagonal. I like to teach the person to stroke this muscle themselves as homework. It's the easiest to access. It's not uncommon to find trigger points in this muscle that have a secondary pain referral going somewhere else, sometimes into the eye or sometimes into the jaw as well. In the supine position, stroke this muscle from origin to insertion in reverse. If any adhesions are found, go against the grain and smooth out any restrictions. In some instances, holding the restriction until it softens is helpful. Temporalis. Temporalis, pretty much about 1.5 inches above the ear. It's a very thin muscle. The most restricted area is not actually able to be palpated. So in a sense, what you're doing is you're pushing through the skin, and in some cases you might find little adhesions or little ridges to try and smooth out. Using gentle fingertip pressure, working 1.5 to 2 inches above the ear to treat this muscle. Holding any sensitive spots until it softens is helpful. The medial pterygoid. The medial pterygoid is on the inside of the ramus of the mandible. It's a very small section that can actually be palpated. You have to push up into the inside of the ramus of the mandible, inside the jaw. It's a very small area to work, so mostly just pressure in 1 to 2 spots is all we can get. Also not uncommon to find trigger points in this area. Treatment of this muscle is performed by using your index finger to compress the inside portion of the ramus of the mandible. The thumb is placed on the outside aspect of the mandible for stabilization. Holding the restriction until it softens is helpful. And of course, always working with the person's tolerance. It can be uncomfortable, but it should never be painful. Okay, so with the jaw work, there's really just two muscles that I work. There's the temporalis and the masseter. Well, maybe a little of the pterygoids in through here. So I work the external portion and then the internal portion. And then there's a nice distraction afterwards. So with this, if you go just below the zygomatic process and you're just stroking to the ramus of the mandible, so just this one area, you can go up, you can go down, diagonal. If you happen to find a little adhesion or a little knot, then just kind of try and work through it. Just hold that static pressure. It's going to be very sensitive, so we have to take this nice and slow. The temporalis muscle is about 1 inch just above the ear. Goes pretty much to there. It's a nice thin muscle. We might be able to find some adhesions in here too, and referrals. Sometimes people comment that it refers into their ear or their eye. And you might want to check out the pterygoids just in case. So this is just in front of the ramus of the mandible, and it's up into this edge right in through here. It can be very sensitive on some people. Okay, and then what's left is the internal portion. Masseter, inside portion. Using exam gloves, place one finger inside the mouth, outside of the teeth. Place the other finger on the outside portion of the muscle. With some individuals, this space might be very limited for your inside finger. If that's the case, have the person take their mandible and move it sideways towards the side being treated. This will provide a little extra space for your finger. Pushing the fingers against each other, stroke and compress the inside portion while also working the outside portion, holding any sensitive spots until it softens. Always work within a person's tolerance. Temporalis tendon, internal portion. With the inside finger directed towards the ear, outside of the teeth, have the person move their jaw towards the side being treated. This will open up a space for your finger to push closer to the ear. Gently, and very gently, because this is very sensitive, push towards the ear and move back and forth. Very small little movement. This is going to be very, very sensitive on most people. We're actually accessing the temporalis tendon. Jaw distraction, internal portion. Have the person gently open their mouth. Place your thumbs on the last bottom molars. Place your fingers around the ramus of the mandible. Have the person close their jaw as much as possible without too much pressure on your thumbs. Have the person relax their jaw. In a gentle scooping motion, push your thumbs downwards while curling your fingers upwards for an average of 10 seconds. I'm going to use my fingers as kind of like ice tongs. Okay, so open. So I'm going to go outside the teeth, and there's just outside the teeth, you can feel that there's the edge of the masseter in through here. If it's difficult to get into, you could have the person move their jaw to the other side. Or, I'm sorry, in this case it would be, there we go. So that allows you to just get your finger in there. There, now you can push the masseter from the outside and the inside. So you're treating both sides of the muscle at the same time. Okay, next is the temporalis tendon. The temporalis tendon is right in front of the ear, and it's at the very end here. Very difficult muscle to get to. Very, very sensitive. You have to really use a lot of, be gentle with this one. So you're outside the teeth. Your finger goes at a 45-degree angle. Then have the person move their jaw towards you. And then opens up that space, and then very gently push your finger up into that, and you're just moving it back and forth a little bit. Okay. And we'll do the other side real quick. Okay. So we're working the masseter, pushing on the inside and the outside at the same time. You can really feel where a lot of those adhesions are. Next from there is the temporalis tendon. Have the person move their jaw towards you and push your finger up into that space. And you don't have to do much movement. It's pretty sensitive in there. The first is the distraction or decompression. So with this, have the person open. Place your thumbs on the back molars. Your fingers are going to go just cupped around the chin. Have them close their jaw as much as possible without putting too much pressure on your thumbs. A little more is okay. Okay? And then just relax your jaw. Let me have it. I'm going to be pushing down with my thumbs and up and back with my fingers. Very slowly. Okay? So that motion is kind of like this. So with this one, have them open your mouth. Place your thumbs on the molars. Have them close their jaw. Okay. And just totally relax. I'm pushing down with my thumbs and up and back with my fingers. Very gentle, very slow move. Hold it for a few seconds. Just a note, I omitted the internal portion of the medial pterygoid. I don't find that treatment to be quite as effective as treating the outside portion at the ramus of the mandible. The treatment you've been able to provide for the person with TMJ issues will go a long way not only to relieve a lot of symptoms, it will help to improve the person's awareness of the muscular tension in their jaw. Along with that, self-treatment or homework can also be helpful. The number one procedure I would recommend is just stroking the outside of the masseter muscle. I also came across this home care for jaw muscles, self-massage for temporalis and masseter, self-massage the internal portion of the medial pterygoid, and also lateral pterygoid. And interestingly enough, stretching of the jaw with a wine cork. Suggestions on what to eat or what not to eat, the effects of heat and cold, and over-the-counter painkillers. One of my favorite post-treatment stretching is active isolated assisted stretching. These movements will not only elongate tight muscles and ligaments, but also re-educate the injured tissue. But it also helps to strengthen weakened areas without activating the stretch reflex. Cervical flexion. Have the person sit up straight and hold back the shoulders. Instruct the person to tuck the chin as close to the neck as possible. Contract the anterior neck muscles and exhale during the movement. The therapist provides a gentle assistive stretch at the end of the movement by using the front hand to provide a gentle pushing effort. The rear hand helps to stabilize the shoulder. 10 repetitions. With each repetition, this should be a little bit easier. You're only holding the stretch for a couple seconds. I would rather stretch 10 times at 2 seconds each instead of one long stretch for a few minutes. Cervical extension. Have the person sit up straight and hold back the shoulders. Instruct the person to contract the posterior neck muscles by gently tilting the head backwards and exhale during the movement. The therapist provides gentle assistive stretch at the end of the movement by using the front hand to provide a gentle pulling effort at the forehead or jaw. The rear hand to stabilize at the cervical-thoracic junction. 10 repetitions. For 2 seconds each. Cervical lateral flexion. Have the person sit up straight and hold back the shoulders. Instruct the person to contract the muscles on the opposite side of those being stretched. Have the person exhale and move the head towards the opposite shoulder. The therapist should stabilize the shoulder on the side being stretched to prevent compensation. Give gentle assistance for 2 seconds at the end of the movement. 10 repetitions of 2-second stretch each, and also repeat on the opposite side. So have the person using their anterior neck muscles. So if you have to, just tap like this, and then if you would, slowly bring your chin to your chest, just using these muscles here. And it's elongated the ones in the back. Then when she gets to the end of that range of motion, just give her a little bit extra stretch, just to stretch that out. The next would be extension. So with this one, she's going to be going backwards, and I'm going to be tapping on the posterior neck muscles back here. So just use these muscles, and she goes to her range of motion, and then I'm going to just give her a little bit extra stretch, just a touch, just to stretch those out. And then the side motion, if I were to tap here, bring your ear to your shoulder, just using these muscles, and it's stretching these out. Then I'm going to give her a little bit extra right at the end. Okay, and then the other side, just using these muscles here. Kinesiology tape treatment. I found by using the addition of kinesiology tape after my treatments has accomplished 2 objectives. It affects the sensory receptors to help the person to be aware of areas or positions they might have forgotten about. It also aids in mechanical correction by utilizing the stretching qualities of the tape with pulling where it's needed to stimulate a sensation, which results in the body's adaptation to the stimulus. Essentials for application: make sure the area is clean. Alcohol is also a good medium to use before the application to remove any oil or residue. For overused or tightened muscles, the tape is applied from insertion to origin. For chronically weakened muscles or where the increased contraction is desired, the tape is applied from origin to insertion. The first 2 areas are optional but appear to be helpful. Scalenes. Cut the tape in half because of this small area. Split the 2 halves to make a V. Attach the 2 ends below the clavicle with 25% stretch. Have the person rotate their head away from you. Apply the anchor point with no tension on the side of the neck. Pectoralis minor, also optional. Cut the tape in half as before because of the small area. Split the 2 halves to make a V. Attach the 2 ends at the level of the 3rd or 4th rib with 25% stretch. Have the person rotate their shoulder away and down from you. Apply the anchor point with no tension just below the clavicle. Posterior neck. Split the 2 halves to make a V or use 2 separate strips. Have the person flex their head away from you. Apply the anchor point with no tension just halfway at the medial border of the scapula. Attach the 2 ends with 25% tension up into the neck. Be careful not to go up to the hairline. Kinesiology tape. I like to use KT tape because it's already pre-cut. So you take one of the pre-cut tapes, cut it in half, and it's pre-split right there. So I'm going to separate the paper backing, just like that. And just leave a nice anchor point there. So you want to take the 2 ends and attach that to around the area of the clavicle or just below. Fold backing off. So just a little bit of stretch into there. Now I have the person rotate away from you and make sure they drop their shoulder. And as they do that, then you want to place that just lateral to the sternocleidomastoid. And there's no tension there. Make sure to rub it in to activate the adhesive. Okay, get straight down. With pectoralis minor attached to the third, fourth, and fifth rib, and it goes to the coracoid process up here at the scapula. So if you would place the tape about the level of the third, fourth, or fifth rib. "25% stretch, just a little bit maybe. Have the person rotate their shoulder away and down. So externally rotate the shoulder and then bring it down like that. There we go. And apply that just above the clavicle. Okay, with this last piece to tape the posterior neck, take your tape and the pre-cut ends, make sure that you break the back, break it all the way down, and then it'll stop right there at the anchor point. Then we're going to break off the backing to expose that one, and we're going to take that anchor point and place it down approximately about the medial border of the scapula. Okay, then we're going to take the two ends and we're going to lay them around the side of the neck. So if you would flex forward with your head, and that's going to put a stretch into that area, and then lay it down right there alongside the neck. Maybe about 25% tension, doesn't have to be very much. Okay, and come back up. Self-treatment. Other than the treatment you've given, the person's best chance for success with their pain is realizing that the management of their neck and their jaw is their responsibility. Self-treatment will be more effective in the long-term management of their pain than any other form of treatment. Neck retraction. This movement re-educates muscle tissue and gives the person feedback when their posture is correct. Have the person fully retract their head as far as possible. Then release the last 10% of this movement. A few repetitions a day, especially while sitting. This helps to keep their neck nice and mobile, as well as moving the C1 and C2 joint. So have the person put their finger on their chin. Push your head straight back, and then slowly let go, and then relax. Okay? And then try and do that a few more times. So a few repetitions of this a day, especially while sitting. I hope you enjoyed this course, The Neck and the Head. If you'd like to contact me, please go to advancedmassageeducation.com.